So I just want to welcome everyone. Thank you so much for being here today. I see people are still joining us, but we'll go ahead and get started in a minute and then just allow people to continue entering in a few minutes. Okay, so we can go ahead and get started. So I first want to thank you for joining us today for the chat panel series, Mistrust, reporting contemporary harms and identifying protection measures for communities of color, featuring Drs. Ben Levy, Paquette, and Lee. This is the second of a three-part series to discuss the complicated relationship between academic entities and communities that they are supposed to serve. The Center for Health Equity Transformation, or CHET's mission, is to lift health for all by exposing root causes of health inequities and by serving as a hub that pushes boundaries in research, education, workforce development, and community engagement. Our vision is to bridge the gaps between research, community needs, and policy by transforming systems and structures so that everyone has the opportunity to achieve their best possible health. The Discussions of Mistrust in Healthcare and Research Entities series are centered on having open conversations about academic research distrust in communities of color via Q&A format navigated by a facilitator. The first panel, Mistrust, How Academic Entities Instilled Fear of Research into Communities of Color, provided a historical context on lack of trust between academic entities and the community. The perpetuation of systemic and structural racism by academic entities has resulted in current-day mistrust. In today's discussion panel, we'll explore participant protections, as well as detecting and reporting contemporary harm. It is my pleasure to introduce today's facilitator, Dr. Lee. Dr. Lee is a gynecologic oncologist at University of Chicago, who specializes in the diagnosis and treatment of women with gynecologic cancer. Dr. Lee's interests include patient-centered research in cancer survivorship, supportive oncology, and cancer disparity. She serves as the University of Chicago Comprehensive Cancer Center's Assistant Director of Community Engagement. Through this role, she supports ongoing community collaborative education and research to reduce cancer disparities in the surrounding Chicago communities with a personal focus in breast and gynecological cancers. At the national level, Dr. Lee is the chair of the Patient Education Committee of the Foundation for Women's Cancer and a member of the American Society for Clinical Oncology Survivorship Committee. I will now turn it over to Dr. Lee to kindly introduce today's panelists.
Thank you very much for having me and asking me to be a moderator. I really think this is such an important series of topic, and I was particularly really excited about the really interdisciplinary nature of who is speaking today. Dr. Ben Levy and Dr. Erin Paquette. Firstly, Dr. Ben Levy is a senior instructor in the sociology department at Northeastern Illinois University. He's a scholar of ancient and continental philosophy, African American studies, education, sociology, curriculum, and disability studies. He's also a scholar of ancient biblical, ancient Egyptian, ancient Nubian, and Gnostic literature. His language facilities include ancient Egyptian, Aramaic, Coptic, Hebrew, Masoret, and French and Spanish. As a prior comparative literature major, that is a very impressive, a very wide range, and I am thrilled to have your perspective today. Dr. Erin Paquette is an assistant professor in the Northwestern University Feinberg School of Medicine, Department of Pediatrics, and the Northwestern University Pritzker School of Law by courtesy. She's also an attending physician in pediatric critical care medicine. As a physician, lawyer, bioethicist, Dr. Paquette is committed to interdisciplinary scholarship, integrating empirical findings into policy and practice. Her primary academic interests include research, advocacy, and policy development that reduces health disparities, addresses bias, racism, and other structural determinants of health, and promotes social justice. Her current research involves evaluating disparities in research enrollment and participation, the use of medical legal partnerships to address the social determinants of health, understanding provider and public perceptions of brain death, and addressing social and structural determinants of health that contribute to this critical illness. I think this is going to be an exciting discussion to really kind of think about this portion of what we think about when we're thinking about the idea of mistrust and consent, and the idea of how do we really best bridge this gap that can sometimes happen between participants in trials and different things like that, as well as consent forms and contemporary harms as well. And I always think of this as a really important topic because there's things that we as researchers spend time on, and then there's the things that we can communicate, and how well do we communicate that to our participants. In particular, when I think about sort of in the US, the common rule is something that those of us in the research facility often get reminded whenever we have to do our city training. And we think about like where we hear it over and over again, and that this was a rule that was implemented to provide protection to vulnerable populations from really egregious research abuses, such as the ones that you may have heard about in the first session, including Puerto Rico birth control pill trials, the Tuskegee syphilis study, among many others, unfortunately. And the adoption of this rule is really what's resulted in like the current day consenting standards for participants and how we implement this through our institutional review boards. And I think this is a really important foundation, but I do think sometimes it's so far from when it was instituted, it's always good to re-look at and how this comes into practice. So my first question is for Dr. Paquette. Have these protections impacted how marginalized communities who may have been traditionally marginalized or abused in research practices, has this affected how these communities view research?
Thank you, Dr. Lee, both for that introduction as well as for how you framed this discussion and for this first question, which I think is a foundational one. Have we set up a research infrastructure that does what its stated intent was, which was to protect vulnerable populations? While many may be familiar, I just want to take a second to step back and identify how the common rule sort of came about. And it came about in response to some of the research atrocities that Dr. Lee mentioned in terms of contraceptive pills being evaluated in housing projects in Puerto Rican women, many of whom really didn't feel adequately able to consent to their participation in those trials, 3 of whom died in the trials, though cause of death was never clearly attributable to the birth control pills. And then the Tuskegee syphilis study, where we know African-American men were denied adequate treatment for that condition in order to study its natural course. In addition to that, the development of the common rule really followed a world reckoning that came about after World War II with research atrocities that occurred to prisoners of war during that time, and the world development of guidelines around ethical research, including the Declaration of Helsinki, and then the Belmont Report, which was a report in the United States about how to adequately get people to be informed and voluntarily give their consent to research participation. And so through, sort of that historical background, the common rule came to be. And I think while its intent is to protect vulnerable populations, what it has done is empowered them with regulations that allow their choice about participation in research. But I don't think it's gone far enough really to reverse the perspectives that individuals who may have manifest mistrust, and I like to refer to it as because of lack of trustworthiness within institutions. So these aren't characteristically distrustful or mistrustful people. They're people that have difficulties with trust in healthcare institutions, and research institutions really have generated that lack of trust because we have not created systems that are trustworthy enough to garner that trust. And so I think that we do have a way to go in terms of how we really change perspectives about the research enterprise and the healthcare enterprise and its attention to rooting out structural racism and disparities.
I think that's a really good point, because I think it's a gap of like, did we go far enough? And do you get the sense that when we're thinking about participants or communities, like, have we even communicated that these rules exist? I know that sounds like a very basic question, but when we do consent someone, do we do, or how do we do, or how should we be doing a job of explaining about the recognition of this, I guess, like you said, this lack of trustworthiness, and acknowledging that, and do even people know about IRBs and about this structure that exists beyond it? And or is that too much for somebody who's going into decision making about a trial?
Right. I think there's always a balance between particularly trials that could provide benefit to individuals. I think there's a balance between providing enough information that allows them to make an informed choice, and not providing so much information that the decision itself becomes overwhelming. That being said, I don't think we go far enough to frame consent and the reasons for consent in transparency about the institution's understanding and acceptance of the prior harms that have been committed in research, and the need, because of those prior harms, to really ensure that individuals understand what they're getting involved in and make a voluntary choice. And I think that the fact that we probably haven't gone far enough to change perspectives is reflected in the fact that Black Americans are far less likely to participate in clinical trials where consent is required. I think it's equally interesting that if you look at studies, there was a 2018 paper by Kesselheim and colleagues that looked at studies that had exception from informed consent. So there are certain study designs where it's not feasible to get consent and enroll people in an appropriate time period. And if you meet certain criteria, including getting general community consensus that it's acceptable to proceed with the trial, you can proceed without and enroll individuals without getting informed consent from them. When you look at those studies, Black Americans are more likely to be enrolled relative to their representation in the general population, as well as in the disease that may be studied in that particular research study. And I think that that's troublesome, because it really, I think, is potentially not respecting the fact that we know that there are lower participation rates when people are asked to consent. And if we're over enrolling in studies where consent is not required, I think it risks further eroding trust in the research enterprise.
No, I think you're totally right. Dr. Levy, can you comment a little bit about, sort of these protection measures that we have in place to make sure that we've, gotten informed consent, and, what could be measures that we think we should be thinking about to better foster sort of these protection measures, really articulating those measures and potentially promoting this type of trusting, either relationship or collaboration, in your opinion?
Okay, well, can you hear me?
Yeah.
Okay, great. Well, first off, I think that we kind of putting the cart before the horse. One of the fundamental issues that seems to be constantly overlooked when I hear these things is the lack of education, the lack of training, the lack of courses in medical schools where people are coming in to become physicians that have absolutely no knowledge of the history of Black people in America, have absolutely no knowledge except for what they see on the idiot box, have no knowledge of the early history of medical experimentation going back into the 1830s, to look at the documents back in and look at the peoples who were involved there. We always like to start out with Tuskegee, which was something that the federal government and the federal government's health administration imposed on them. Or we look at Henrietta Lacks, and I mean, her cells have done things beyond measure. But what about the medical experimentation that was done on Black cadavers back in the 19th century? What about the research that was done back then? What about the branding and abuse that occurred and the consequences of that on people who all of a sudden now we want to come and ask them to get engaged in research, which I think is important. But at the same time, they intuitively recognize that this is not good. There has been a lot of negative stuff that has come out of this. And that is fundamentally because most physicians, the overwhelming majority, know nothing about us as a people in this country. Don't want to know nothing about us as a people in this country, and decide to go along with the nebulous, white nationalist, white supremacist notions about what they think Black people are. You still teach that Black people got thick skin and stuff like that, so we don't feel any pain. That goes all the way back to Immanuel Kant, talking about that in the 19th century. The fact that, we don't have the cognitive ability to understand what's going on. That goes back to Jean-Jacques Rousseau when he talked about cogito ergo sum, right? I think, therefore I am. But if it's assumed that people can't think, therefore they are not, they don't exist, then why should you be worried about trying to figure out what's going on with them on the inside? And these are things that have not been established as curriculum in medical schools, because so much of the focus is on clinicians, clinical work. But what about the common basic insights that we need? And don't get me wrong, I know that in medical schools you study, everybody knows about James Merriam Sims and what he did to Arnica and Bessie and those ladies. We know about all these different people who did these things, and yet we don't talk about what that means to getting people to get engaged in, clinical research. And so I think that, that is the fundamental thing we have to do, because we got a lot of people out here who have African Americans as their patients, who look at them and think of them as something other than humans, you see. And that goes back to the great chain of being theory, now doesn't it? That people evolve from, savages to barbarians and then to civilized, and they're always viewed as being a part of the savages and the barbarians. And this is very, very unfortunate, because that line of thinking permeates the way oftentimes research is done. And so when we get to the point where we're looking at the research that is being done and the papers that are being written and stuff like that, nobody wants to go back there and talk about that. Why? Because of the idea of progress. See, progress says you never look back, you always look forward. But if you never look back, you'll never understand how to even to get where you wanting to get when you go forward. And so for me, this is very important. But here's the other element to it. And our society, the environment is permeated with this. Oh, we don't want to talk about those things because that'll make people feel uncomfortable. We don't want to learn. We don't want people to talk about this or that or the other, because people might feel that their kids are going to be impacted by this in a negative way. Let me tell you something. African Americans have been impacted by negative stuff since the moment we first got here. One of the first negative things that impacts us when we go to school is this: I pledge allegiance to the flag of the United States of America and to the republic, not the democracy, to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. And all the people, then you want to get involved in research, remember saying that and looking at the reality they see out there and say, this is a bunch of nonsense, this is a fallacy. So until I think we fairly address that at the curricular level and get physicians, many of whom come here from other places, don't know anything about us. And we don't know anything about them. And that's unfortunate, because we're the most geographically illiterate nation on the planet. And we all know this. But until we get to come together on that level and get to understand it on that level from the curricular level, then all this other stuff, while it is beautiful, people are still going to go in with a certain mindset that's going to throw everything off. And until we get that squared away,
I totally agree with you.
A lot of this is just going to be conversation.
No, I completely agree with you. I think it's really beneficial the structure of like even the medical education system, the controversies that and the abuses that have been happening, and this idea of, you know, even when we study in medicine, for example, when we study the idea of like disparities, right? So we posit this as a disparity, but we don't, you know, it's that whole idea of like, is it really race or is it racism, right? Like, is it really race that's driving this, or is it the, you know, the really holistic effect of being in a racist society, you know, structure, both the structure that medicine has kind of come from. And I completely agree with you that like, and I don't want to sound too Pollyanna about it, but I am glad that there is more of those types of like actual foundational courses in more medical schools. And now our graduate medical education requirements actually, and again, requirements are one thing and what's actually in place is a whole other thing. Right. But I do think that that is where those changes have to happen, because our graduate medical education requirement has a whole series now on not just disparities, but this idea of like, how are we talking about these issues? And so a lot of different, you know, for example, in GYN oncology, that's one of the main areas that we've actually really developed. That's just one example. But I think that there's always, as you mentioned, like really trying to think of that as the center of like what we're building everything else out of. And I wonder if you think that like, that means that we have to change the way we think about the research design, the way we need to think about who's involved with the research creation, and then also who's involved with like understanding how consenting happens, and like who's involved with writing the consent forms in terms of like, do we have enough community involvement? Do we have enough patients with that specific disease involvement? So I think all of those things, I'm throwing them back at you to say, what do you know?
Yeah, I think that all of that is true because, for example, in the work I do in cancer research, prostate cancer research, you know, we discovered that the Gleason scale is designed more toward white men.
Yes, exactly.
And not black men. I mean, black men are sometimes considered for biopsies because it appears that they have a higher Gleason scale, Gleason score, when in fact they don't even need a biopsy. You know, this kind of false positive thing. And yes, I think that, you know, we need to have more, you know, I'm much more comfortable being engaged in some activity if I feel that I am, you know, involved in it, if I'm, you know, vested in it in certain kind of ways. And then I can go out and advocate for it. You know, and we did our major prostate cancer project, which was very, very successful. One of the things that we were able to do was to bring in, you know, Black men who were prostate cancer survivors, such as myself, and others who also had, you know, letters behind our names, who could also engage in relationships.
Yes.
That's really important, to have relationships with the people that you want to get engaged in the research. If you come at them as a flat out clinician, some people are just gonna walk away from you. They don't have time for that. Yeah. But you gotta establish relationships with them. You wanna talk to them like you be talking to any of your other friends, you know, how things are going with you. And then we can get around to like, has anybody in your family ever experienced cancer? Have they experienced prostate cancer? And then people start talking about, yeah, well, you know, my uncle, my father, whatever, passed away from prostate cancer. I do the same thing in my classes. Every semester, beginning of semester, one of the first things I start out talking with them about after introductions is, how many of you know someone who has passed away from cancer? And more than half of the students' hands raised. Now that takes me on a whole nother level. What types of cancer? Then that thing leads to some other things. Then I can start talking about the kind of work that we do. You see what I'm saying? And how it's important to get people to even thinking about getting involved in maybe wanting to get into this area and study oncology and how they can maybe help somebody else. But it takes establishing relationships. You got to get to know people. You got to get to know them. You got to get to know their backgrounds. And then it's much easier to bring them in. So I think that it's very important that the community be invested in all aspects of the research, because right now it's all about, you know, us MDs, PhDs, and all that other kind of stuff. Like we all know so much, and we all know well that doctors don't trust other doctors in many cases, right? So yeah, Dr. Lee.
No, I think that's a really important point, and I'm sure I would love to email you later to set up many discussions about these topics too. And
No
I'm just
problem.
thinking ahead of time. So,
Yeah, okay.
you know, one of the things that kind of thinking through is this idea, and as we talk about like sort of like, you know, the title of our panel today, you know, the idea of like reporting contemporary harms, and you know, thinking about what do we mean by that terminology? Like what, you know, and maybe I'll shift to Dr. Paquette. Like what you know, from an ethicist point of view, like what do you mean by contemporary harms, and what are those look like in a clinical setting, in a research setting, and what are our you know, what's, I guess I'll start with that, and then kind of like what do you think maybe like how that's shifted over the years, and how do we address them? You know, solve all of that in just, you know, a few minutes.
Someone start the timer. So, you know, thank you for bringing that question up, because I think it's important that we recognize not only the history of harm, but the continuation of harm. I think if I were to choose how to define contemporary harm, I would say that either in the clinical or research setting, these are attitudes, beliefs, or practices that perpetuate lack of trust and therefore lack of engagement between marginalized communities, which include communities of color and medical providers or researchers. And I think that examples of this include failure to address structural barriers to equitable care for Black and Brown populations. And without going into too much detail, COVID is a perfect example of this. We had so much opportunity within the public health infrastructure to not see the wide disparities that we did with treatment of Black and Brown populations in overwhelmed community hospitals, while those who were fortunate enough to make it to academic centers sometimes fared better and had better access to resources. Yet, despite knowing that, we didn't set up as a state, as a local community, systems and structures to ensure that people who needed more advanced care got the right care that they needed at that moment and in the appropriate place. Other states in the country did do that. And so I think there are models that we could turn to, but I think the failure to address these structural barriers to equity is one example of contemporary harm. I think the potential for over and under enrollment of individuals at risk for disparities in research is another contemporary harm, because I think it further undermines building that trust back up in the research setting. And then I think that we have to acknowledge the overt exploitation and harms that are continuing to occur. I think there was reference in 2021, I don't know if people saw, there were several reports of individuals in an Arkansas prison that had COVID-19 who were treated with an anti-parasitic ivermectin that was not recommended by the FDA, in fact, recommended against for treatment of COVID. These were individuals mostly of color and who were told that they were, there was an element of direct deception reported by some, where they were being told that they were being given vitamins or steroids for treatment of the condition, when that was not, in fact, what was the content of the drug that they were given, that wasn't even indicated for the condition. And I think as long as we continue to see these kinds of events occurring, we have like massive contemporary perpetuation of existing harms. And I think we need to kind of address on all of those levels the harms that are occurring.
And I think that's important, because I think to Dr. Levy's point, this is not sort of something that happened in the past and now we just have this, like, you know, we have to get over it type of thing. And I think that that is often when historical examples that are brought up that are really important to bring up in terms of historical context, dating back from, you know, obviously some of the, you know, the different examples that Dr. Levy mentioned as well, and some that you guys have probably talked about on the previous meeting. I think it's the ongoing issues and the ongoing feeling that this is not somebody that is going to advocate for my own health, and I need to be potentially wary of research and trials. And even if I know that it could be good for me, right? Like if the structure, the foundation, and this is from one of our, you know, a collaborator who is a breast cancer survivor. I think, you know, she really brought up to me, she's like, if my first instinct is, I don't think I should trust this, that is a problem of the system that has been, has sort of created. So I do think that this idea of contemporary harms and like are addressing that ongoing. And I wanted to throw out, I think there's also a worry that, how do we shift the conversation from this idea of like, quote unquote, those communities mistrust us, as to say, like there's like that mentality there. And the idea that like, it's really, a lot of clinical trials participation is the bias of practitioners not offering the trial and not asking. And then people, if they were asked, they would do it, right? So it's sort of this, how do you kind of get at both of those at the same time? I don't know if either of you want to take a stab at,
Sure. Go ahead. No, go ahead. Go ahead, Dr. Paquette.
I was just going to say, I think as Dr. Ben-Levy spoke to earlier, I think the first step is education of individuals who become principal investigators on research studies, because they set the tone for how their entire research team is going to implement attitudes and practices that really promote trust and solicit actual engagement of communities of interest, which has to start by asking, what does the community need? Not what do I need as a researcher, but why do I want to do research in this community? What do I perceive as a need? And does that align with what members of that community perceive as a need? And how is my research going to work to address that? But I think that starts with education of the entire team that's going to take part in implementing that research plan. We need bias training, not just for principal investigators, but for entire research teams. We also, I think, need to shift the structure of how we think about making opportunities to participate in research. So it's not only individual biases where people might say, I'm not going to approach this individual from a marginalized community because I don't think they'll attend all the study visits and I'm going to have missing data, right? That's a bias that impacts on an individual level where someone has access to the study. But think about the number of people who are receiving their care for the same conditions in community settings in which there's not even the opportunity to enroll in those trials. And we may have many clinicians practicing in those environments who aren't even aware that they could refer a patient to a trial at another center if they couldn't enroll that patient within their center. So I think there are multiple layers at which we really deny equitable access to participation in research. And then, inadequate education at all levels for how we carry that out in a way that is informed and that is sensitive to the historical harms and the ongoing harms within these populations.
That's very good, Dr. Paquette, and thank you very much for that. Two things came to my mind. I don't know if you're all familiar with what happened with Dr. Maybank at the CDC and how she's out advocating for equity and fairness and so forth, and that she's had death threats.
Yeah. People
spray painted her home and garage, and she has to have security. This is insanity that's going on here for, and what? You see, the people who complain about critical race theory, and I'm not going to go into all of that because I always like to say, where the hell were these people 40 years ago when they were talking about this at Harvard and at UCLA and all of that? But all they do is verify the argument that the people in CRT focus on. Nobody's talking about critical Latin theory. Nobody's talking about Latinx theory. Nobody's talking about critical disability theory. Nobody's talking about critical white theory. Nobody's talking about any of that. Just a race thing. And yet we're told race is a social construct. There's no such thing as race. So what is it? I mean, I could go into, a whole thing of discourse on the origin of the idea, which is one of the things I really push a lot of. But here's the other element. When we're talking about doing this research, one of the models that we established in our research was the idea, it wasn't unique to us, but we were able to do some things with it, I think, that were unique, was the idea of the citizen scientist.
Yeah.
How we train and prepare community people, get them CITI, certified, and give them the necessary training, because they're the people who have the links out there in the community that otherwise we wouldn't have. They can go out and talk to people because of the relationships that they have established with folks out there, and they can much more easily convince them of the importance of these projects, particularly if they have some direct evidence of the impact of whatever we're doing research on, particularly when we talk about cancer, relative to their family or their friends or some of their loved ones. That is some of the most important stuff, because then people are willing to walk in the door now. And they can say, how did you find out about us? Well, my friend over there, he was telling me about this. And who is his friend or her friend over there? One of our citizen scientists that we trained, who knows how to go out there in the community, who's established relationships with these folks. Because once those relationships are established, and then once we start getting them support service that they otherwise may not have been able to get or even thought about getting or were afraid to get, then we've not only gained, a patient, we've gained an ally. We've gained someone who will then go out there and advocate for us too. They're not trained as citizen scientists, but now they can say, I talked to these guys, this is what happened to me. I'm alive to talk about it today. You all should go check them out. And it's kind of like in the old days, we used to have what's called the grapevine, and we could just put stuff out there on the grapevine, right, and it would spread like wildfire. And we didn't have, like Facebook, TikTok, Twitter, LinkedIn, all that kind of stuff, and it moved like wildfire, and we got stuff done. And I think it's the same thing. We have to establish relationships and get the community engaged in the work that we do, make them feel, invested.
Mm-hmm. No, I think this gets at a lot of the topics of like how to better make sure that the research is really meaningful for, both the methodologies used, but also the topics that are centered. And I think it really gets at that. One of the, and I appreciate our team kind of thinking through some of the prompts that we want to talk about. And one of them that I really loved was this idea of like intention over impact, or intention and impact, right? So like, what are research teams and, team members or the whole clinical research spectrum intending to do? Do they, articulate their intent, and how do we measure impact, and how do we hold like our academic institutions and our individual researchers, not individual researchers, like the research community accountable for what they're doing now? I don't know who wants to tackle that one.
I think that, again, folks have to realize that, I like to tell students all the time, when I walk on the street or I'm driving my car, and if I get stopped by the police, do they know that this is Dr. Ben Levy? No, I'm just another Black man out there. And even if I might even say, well, I'm Dr. Ben Levy and I teach at Northeastern, and show them my card and still get my butt whipped. Oh, you think you're being so much better than me, or this or that or whatever, but we have to be able to help people understand that, when people talk about being all in this together, we're all in this together. Are we really? Because being all in this together means just that, being all in together. And as not only a community of clinicians and professors and scholars and all these types of things, we have to also look at the community at large out there, because without them, all in doesn't exist. The work we do doesn't exist. And so we need to find a balance in which we can do that. Now, I'm a big advocate of this. I used to run into people on the street who may have heard me on a TV show or something like that, who would ask me, can I come sit in on your class? And I tell them, sure. Now, I know a lot of universities are like, well, they're not registered, they haven't paid their money, so they shouldn't sit in class. But let me tell you something, I've recruited a whole lot of students by letting that person whom I saw out there on the street, who heard me, come and sit in on my class and hear me teach, and then ask, damn, I like this. How can I get in on this, right? How many people out there? I have a student right now, my research assistant. She wants to be a physician. She's working hard at it. She's graduated. She did all the biology. She's doing extra study, and so she's graduated and stuff like that. And she is determined to be a physician. And I told her parents, because her dad told me, I don't give a damn if you're in your wheelchair, Dr. Believy, I'm wheeling you in to see my daughter walk across the stage, right? But how many students are there like that who would love to do this? Right. But they don't have any inroads. So we're looking at, well, you know, their MCAT score is not high enough. All of us know when you take those tests, oh, you pass the test, but none of that stuff has anything to do with what you're going to study when you're in school and what you're going to do while you're out there working. That's for sure. That's why I'm opposed to all of that stuff, you know? And not only that, we need to provide support for folks. You know, we need to provide support. You know, everybody talk about the educational system is not good and stuff like that. Okay, then we need support. Because guess what? When you're out there working in your professions, when you're in your teams, what are you all doing with one another? You're supporting each other. Some people going to come up short. You try to pull them up because it's a team.
Yeah, I think that really gets to this idea of how it's not like one, you like kind of bringing it back to this idea that it really has to be like how, like who is at the table at all of these different levels. Yes. So the investigators, the research staff, the navigators, you know, so like diversification and really across many different types of domains has to be sort of simultaneous. With, you know, so all of these efforts kind of like come together, and I do think that that's a really important point in terms of some type of like concrete, you know, how do we move that forward, like a concrete, you know, in that sense.
I would just add to that I think funding mechanisms can be one way to actualize that goal. If it's required that there is community advisory board or participant involvement from the very beginning stages of research. And then if there's a requirement that outcomes track along interest to the community. So we ought not only be measuring the outcome that might be inherent to our research goal, but we must include outcomes that are relevant to the populations that we're engaging. And I think the other thing that I really appreciate about what Dr. Benlevy said is that it's about bringing people through the system and into the practice of medicine and research that reflect our communities. We talk about trying to promote diversity, but we're not there in any regard. We don't have research teams that reflect the diversity of our communities. We still don't have clinical teams that reflect that diversity. And I think we simultaneously have to start really committing to that idea and utilizing programs that elevate the voices of the underrepresented and give them the support they need to step into these roles. And then at a regulatory level, requiring that researchers hold true to those goals. They hold true to enrollment targets that are reflective of the populations that they're studying. And I think, until we start to really enforce that by not permitting funding or, NIH dollars or publishing results, we have to have some measures of accountability that really help us to get to those goals.
Exactly. And I'll add one word to that. It's a 4-letter word, by the way. It's called fear. Fear. I don't know what people are fearing, but it's fear, fear that somebody might get ahead, and stuff like that, a whole host of, black towns outside of Tulsa that everybody knows about, Wilmington, North Carolina, several others were destroyed out of fear of Black people having success and standing on their own. And then when that happens, then they'll say, well, those people are lazy. And I can make cases for the reverse, but, it's fear. And we need to get over that fear. And again, I agree with you, funding needs to be put out there. There's dough out there. I was at one meeting, I won't say where a team was awarded $25 million. I almost fell out my chair. Not that I was getting any of it. To do some kind of studying. And I'm like, but
this brings up I'm going to diverge a little bit. So Yesenia, let me know if that's okay. But it really brings up the funding question. Oops. Oh my goodness. I thought I lost you guys. Brings up the question of ironically, as more discussion has been paid to the issue of disparities and health equity, people have written about the idea of health equity tourism in the research space, right? So people who were not doing the work of community capacity building, not doing this work and necessarily before all of these grants have now become available, right? And who's getting those grants and which institutions are positioned to get them because they have the infrastructure and which don't. So I think it brings up this idea of like, even as funding mechanisms are put out there, which is definitely needed, are we also seeing how they're equitably distributed and how they're, like how where is that money going?
Yeah. Everybody's engaged in what I call NIH, and I won't say everybody, that's generalistic and it's not right, but to just say that there are people who are engaged in NCI and NIH side hustling. I attended a conference once where a lady talked about she got $1 million just to sit around and talk with Black men. She was a white woman with $1 million to just sit around and talk with Black men. I was like, you mean tell me there aren't Black men out there who are not worthy of getting $1 million thing to actually go out and talk with Black men about stuff that Black men are interested in since we're Black men? I mean, my goodness, you understand? And to me, that was just a hustle. I couldn't see anything that came out of what she had done based on her presentation that was of any value whatsoever in terms of changing the trajectory of health and healthcare in the Black community by what she did, none whatsoever. That has to change. That has to change.
I wanted to add to that, if possible. First, I wanted to just bring attention to one of the comments in the chat that Jen Brown just added, which I wholeheartedly agree with, that, in addition to infrastructure accountability, there has to be some measure by the community itself about whether the research has had the impact that the community desires. And I completely agree with that. The other thing I think that we ought to consider is, because there is, in the research setting, there will always be the go after where the money is approach to research. I think we have to try to have really strong vetting mechanisms, not only for those institutions that have infrastructure, but for those teams who are really, truly committed to this work. And, I think requiring both health equity impact statements, community impact statements, but also potentially, when you apply looking at academic positions, many times now you're also required to submit a diversity and inclusivity experience and impact statement with that. And I think, that we need to think similarly in research teams, like who is qualified, passionate, and committed to this work. And we need to try within that to support groups that might not have the infrastructure, but need that funding in order to be able to do really important things.
When, I appreciate that comment as well, in terms of this idea of like measuring or documenting accountability and like what are the mechanisms. And then this kind of comes back to kind of a question that I had kind of skipped over a little bit before, but like, how do we not only have those mechanisms, but how do we report from a community perspective when we think a research is not doing that, or is inflicting harm, or is not being as equitably distributed? And do we have mechanisms in place at our own institutions to do that? And is it through, Dr. Levy, as you mentioned, like making sure that the citizen scientists are involved, or is that the mechanism, or are there tools? Are there hospitals get like score report cards on different things. Like, is this something that we need for research? I know I'm just throwing a lot of these things out there. So like, how do we document it? And is there any, I don't know, other people in the audience can put it into the chat about like, are there any other examples of this that we can like look at?
I think when you're doing community engaged research, having citizen scientists or stakeholder participants, or however you call them, as part of research teams is one mechanism to try to represent the community. But I think it's important to recognize that those individuals may not reflect the viewpoints of the entire community, or be able to really identify group harms in the roles that they serve. And when thinking about this idea of community engaged research, I think one of the things that I've written about and thought about is that we need to have a way we ought to have mechanisms that we put into our research plans and disclose to community members about who they can go to with concerns about the research that maybe doesn't include their group representative, because they may be worried about losing group identity or belonging by trying to go up through that representative. So I think the same way we have ombudsmen within institutions, we need to have plans for who do you report to? We put a line in our consent documents. If you have concerns about this research, contact, but it's part of that boilerplate language that I don't think oftentimes gets called out in discussing research with individual participants. And so while I think it's important to have community representatives, I think it's also important to have a clear plan and identification of non-involved individuals that participants could go to with concerns.
Yeah, that's really good. It's a really good point.
Yeah.
And somebody put in the chat here that a lot of times it's the PI.
Yeah, that's what I said.
Is the one, right, the PI that they say contact the PI, but no, what you're saying, Dr. Paquette, is that they need to talk to somebody else.
Right, because the PI is sometimes the person giving the treatment, and they don't want to, I wouldn't want to make my person who's giving my treatment,
Right. Yeah, you might get the wrong thing stuck in you the next time around.
But at the same time, you feel that way, right?
Absolutely. I think that's a very good and positive idea. It's a matter of, and I think that this should be written up in a way that it be included in the consent forms, and that the person who is there overseeing the person filling out the consent form make sure that they point that out and say, look, if there's something here that, this statement is about this, if there's something here that you don't really see right, then you need to contact XYZ person, and we need to have them write it down. Because see, once they sign the form, even though that statement is there, they may not remember the number or the name of the person that they're going to. So they need to have a way of knowing about that, because that creates a certain amount of checks and balances.
I like that a lot.
In terms of how we do our research. And people who are trying to do stuff, maybe intentional or not intentional, that are somewhat nefarious, can be put in check.
I did want to ask Dr. Paquette, in your role as in the law school as well, do you think that law and policy have a role in these types of comprehensive protection measures, or when things are more when harm is more egregious, or I don't know how you feel law and policy fits into this as well, right? Obviously we're having this discussion, and a lot of it has been geared towards kind of the clinical space and the research and the community space, but how do we bring that to another level, I guess? I don't know.
Yeah, I would say a couple of things. First, I would say I think it's important to think about the different types of law, so that laws that we think about in the traditional sense that Congress debates, they take years and years to get implemented. So they don't have real-time impact. Regulatory law, which is created by administrative bodies like the Department of Health and Human Services, those types of regulations, they still have to go through a process, but they have a shorter time frame from proposal to implementation. And in fact, the laws that we follow, or the common rule, is really regulation. It's not statutory law. And I personally think that we're, like I said, I think this first set of laws came about with a world awakening to research atrocities across the globe. I think we're in a second reckoning right now, where we're thinking about this in the clinical space, in the research space, in the public health space. And I think that it's time to update our regulations to reflect that. Our current regulations, they ask about considering individual risk and benefit in research studies, but in a lot of community engaged research where we've identified a community or identified a group, there can be stigmatization with that research that impacts a group, not necessarily weighed at an individual risk benefit level. There's not really a way for IRBs to weigh that in their consideration of research plans, nor is there really a way to weigh community benefit. While the idea of community benefit has been brought up as important in other research ethics documents, it's not part of the IRB charge to look at the benefit to the community. It's really narrowed to the individual participant. And while I think that risk benefit to the participant is critically important, I think when we think about communities, when we think about labels that we put on groups, we need to think about the impact on groups as well. And we don't do that effectively under the current regulation. So I think they're due for an update. The last thing, though, I would say about the law is that the law is really a floor, and we can do better than what the law requires. And all of the things that we've been talking about in terms of improving education, improving access to research, making funding structures that hold research accountable, creating publication guidelines, like how we use the term race and racism in publications. Those are all things that aren't required by law, but we can recognize as an academy and as a research community are critical if we're really going to start to repair the broken relationships from the research misconduct that has occurred to date and continues to occur.
Yeah, I think that one of the other things, and speaking about it from a legal standpoint, and I'm not really like a legal guy, but I read a lot of legal stuff. And when we're looking at how we want to maintain the right to doing all of this the right way, we have to be conscious of one group of people, one group, one organization that influences a lot of legislation, no matter what it is and for whom it is, and that is the American Legal Exchange Committee, or ALEC. ALEC has great influence on legislation. They even write legislation that gets passed. If you're not familiar with ALEC, I would suggest you go out to their website and look at all of the powerhouse corporations that are signed on to that organization, and even look at the various legislators that they back. You know, Elon Musk raised this question. Someone asked him a couple of weeks ago, how is it that you don't pay any taxes? He said, how many congressmen and senators do you own? How many congressmen and senators do you own? That's powerful, because we're talking about, you know, the idea of, you know, Derek Bell talked about this when he wrote in the Harvard Review about the Brown 2 decision, and he talked about interest convergence. And the idea of interest convergence is that you have people who are very, very powerful, very, very wealthy, who have stuff that we want to get from them, and they'll ask us, well, how does your interest converge with mine? And another way of saying is how am I going to make money off of you? You know, kind of disaster capitalism. And so consequently, you know, we need to be conscious of this when we start to lobby and write and stuff like that. Who's going to be watching this? Because you got to always understand that people who have power will never train people who have no power how to take that power away from them. You understand? People who have power will never train people who have no power how to take that power away from them, and they're going to try to give you as little of that power as they can. They'll give you enough to make you think you got something, but you really have nothing. And we have to really think about that. And that's kind of a long range thing that we have to think about. But we need to consider it when we're talking about, because all of us here, we're serious about saving lives. Powerful people don't care about us or the people whose lives we're trying to save. They'd rather they all die. But that's not what we're about. We're about saving lives. You know, and we have to keep that forefront, you know, in the forefront of our minds. To quote from my favorite folks at the University of Chicago, Dr. Rubin is my daughter's, she's like his baby, you know, in Crohn's and the work that he does. So I tip my hat to him every day for saving my daughter's life. So I understand how important these things are, you know. I understand my doctors who, if it weren't for them and doing the work they did with me in cancer and prostate cancer, I wouldn't be here today to talk about this. So I am passionate about the idea of saving lives. You know, that's what it's all about.
I could say one last thing about the law that I think it's important is that we also are attentive to when we're allowing the passage of laws that will perpetuate disparities. And to give an example of that, you mentioned that I've done, or I work right now doing research trying to ascertain perspectives on brain death. The concept of brain death came about within a Harvard committee that was made up of a very singular demographic in 1968. And since that time, it's endured a number of challenges, many of which have arisen from marginalized communities who don't buy into this construct, which some have called a social construct of brain death. And so much so that the law is there's considered revision currently by the commission that drafted the original law. When I look at the composition of the group that is discussing that revision, again, it fails to reflect the diversity of our communities and viewpoints within those communities. And if we don't take efforts to make sure that the laws that are created bring in the diversity of viewpoints that we have, we're going to continue to create systems and structures that allow ongoing disparities and marginalization to occur. So I think we have to be very mindful, even in laws and regulations that don't pertain directly to research, that we're not worsening already strained relationships.
Mm-hmm. All very true. I'm sort of like floored. I feel like we could go on for like another hour to talk about each of these topics individually. I'd like to ask our speakers today, really, when you think through these issues, do you think that, what are the things that are there any topics that we really didn't, touch upon as much as you would have, wanted to kind of get into, and this may be future talks and future discussions as well, in terms of how do we move that, as we've kind of created this space where, people are sort of all on the same page, or at least we've been talking about the same things, like where do we go from like more, I think we could probably come up with a list of what's been in about concrete measures, and where do we go about these continued conversations, or anything else that you'd like to really leave our group with. I would love to hear where your thoughts are.
Let me start with, right now I'm teaching a class, it's a relatively new class called the Sociology of Aging. And it's a really great class because, as I tell my students, most of whom are under 30, if you live long enough, you're going to get old. And there are some things you need to be aware of as you age. And the whole gerontological study, I think it hasn't been given that sense, because America is a youth-oriented society. It's like ancient Rome was. We all want to be young and have fun. They say, have fun, die young, make a beautiful corpse. And or the problems of suicide among the youth, but especially agedness and ageism, and what aged people go through. We're talking about, since I know directly on these things, my stepdad died from Alzheimer's. I understand now that I saw the progression of it as it was happening. And then when it went full blown, 4 or 5 years, they usually say after that, you're gone. And really 5 years later, he died right there in front of my mother in her presence. But that, the day I walked in and my mom introduced me, and he was like, I don't know who that is. And immediately it first kind of hits you in your chest, you know what I mean? Like a gut punch. But then, as a person who understands these things, I said, hey, Dad's got Alzheimer's. And now it's really getting bad. He doesn't even recognize anybody but Mom. And he passed away. A month to the day, my mother, and I think this is from the stress of losing, my stepfather and all of that. A month to the day, my mother falls, bumps her head, has a massive stroke, loses 80% of her capacity. I mean, this is the traveling grandma. You understand? Traveling grandma is gone, loses 80% of her capacity. So, I'm looking at her now, it's not a question of if, but when, and thinking about the problem with her, what's going on in her brain. And these are things I think we need to talk about, the nature of stroke and how that impacts, especially, to the brain. These are things we need to discuss because this is happening. Mm-hmm. Mm-hmm. And there are other things that it impacts. So, you know, those are things that come to my mind right now because they personally impact me, and I can talk about it with my students in real time.
Well, I think it also brings the fact that, like, obviously we're, you know, a group that's focused a lot on like cancer disparities and cancer a focus, which is very, very important. Obviously, we've all, you know, a lot of us have dedicated our lives into these fields, but it's also the context of somebody's life experience that I think that you're really speaking to, that goes, you know, that it may include cancer, and we may be seeing them at a moment in time, but includes this whole spectrum, like you mentioned, which I think is very true. Thank you for sharing that.
No problem.
Dr. Peckett, is there anything else that you'd like to kind of, as we, oh, you're muted.
I thank you. I would just say, you know, thank you for those comments, because I think what they really do reflect is the fact that, you know, to get better engagement, we need to understand one's lived experience, just as you mentioned. And I think that's critical to formulating research ideas, questions, evaluating impact. We have to learn how do we apply the tools, not only of the fields that we've been trained in, but in other fields that have the expertise to really elicit that lived experience. And creating multidisciplinary research teams can help us to do that. I think a second thing I would speak to is that, again, there's a comment in the chat that things haven't changed in 20 years from the writing of the two Institute of Medicine reports around unequal treatment. And that highlights, I think, the fact that this work is hard and it's exhausting. And so I think it's important to find ways to have small wins to keep the motivation and the passion going when you're working in this area, because the outcomes of proving that something works to promote social justice or reduce disparities doesn't always follow the traditional lines of causation. There are so many interactions between different variables that the scientific method alone can't always get us there. So using all the tools we have at our disposal, I think is important. Understanding patient stories, and then, you know, taking things that are wins for us to keep working, whether that's, you know, getting a comment out in response to a regulation that has a definitive endpoint and impact that that's going to have, or mentoring a student that you know is going to be part of the next generation of researchers in this space. I think we need those victories to keep us moving forward.
I just love that idea, the idea of small wins and how they translate to big wins ultimately is such an important motivating factor. And also probably that we may not even see the ramifications or the, you know, the butterfly effect of like the small wins, like the, you know, the student that Dr. Levy's mentoring and whose dad is going to take him to graduation no matter what, or, you know, we don't see those and we don't measure them. And I think that that's such a really important way to think about it. So I think that that's a great spot. So I think we're sort of at the end of our time together, and Yesenia, I'll have you take over to see what your thoughts are, if there's anything else that you'd like to share with the audience.
Yeah, I just want to thank both of our panelists and our facilitator for this very profound conversation. And thank you for everyone for joining us. We do have our last part of the series on April 20th, and we'll definitely go ahead and share it and hope that all of you can join us there too. Thank you so much.
Thank you for inviting me. I really enjoyed this. You know,
thank you.
You know, it seems like a lot of times I'm like one of the only guy in a room of like 40 women, and I love it.
Thank you also for the opportunity, and I'm humbled to be among all of you in this discussion, including those who've added such important comments to the chat. Thank you for engaging.
Thank you. Thank you very much.